Hi, everyone. Thank you for joining us today with the Alzheimer's Foundation of America for our Care Connection. We are very excited to have Dr. Greg Hinrichsen with us today to present on cognitive behavioral therapy with insomnia for older adults. And so just to introduce you to him, he is a geropsychologist who has spent 40 years of his career in the field of aging, conducting research, providing clinical services, and contributing to public policy. He is also the author of Assessment and Treatment of Older Adults, a guide for mental health professionals, published in 2019 by the American Psychological Association. And so without further ado, Dr. Hinrichsen, please take it away. And thank you for being here today.
Okay, thanks, Kara. Hello, audience. I can't see you, but I hope you're having a good day. I'm talking about a treatment for insomnia in older adults. And I actually didn't have much interest in this topic until I went to work in the Department of Geriatrics at Mount Sinai Medical School. And one of my colleagues said, could you figure out what to do about sleep problems in our older patients here? Because we tell everyone that they should be very careful about giving sleep medications to older people, but the truth is we still do because we're not sure what to do. And so I dutifully got trained in this particular approach. And have just been so struck about how effective it is. And so I wanted to talk about it and some more generally some things about sleep in older adults. What are treatments for sleep problems? And then show some data on clients that I've treated with chronic insomnia in our outpatient geriatric clinic at Mount Sinai, which is called the Martha Stewart Center. I'm not sure where you're all located, but here in New York, I often read the New York Times, and the New York Times has been pretty good about publishing articles relating to aging. There's a section called the New Old Age, and so there are often articles about sleep in older adults. I think because the fact is that's a topic of concern to its older and perhaps also younger readers. And in recent years, there's been increasing concern about the use of different sleep medications for older people. As I had mentioned, the geriatricians, as you probably know, are medical doctors who specialize in aging, have been concerned about the use of sleep medications because, among other things, they increase risk for falls. And they also, people tend to become habituated to them. That is, they need more to have the same effect. And people can show some cognitive fuzziness during the day. And in recent years, there have been studies that have raised some question about whether anxiety-related drugs, which include many of the sleep drugs, might increase risk for Alzheimer's disease. Now, I'm not a sleep expert, but my sleep colleagues say the evidence is not fully in, but there are some studies that are showing that the accumulation of taking anxiety or sleep-related drugs may increase your risk for cognitive impairment. As you can see, here's another article, anti-anxiety drugs tied to higher mortality. So that has gotten people's attention. And now, in recent years, I sometimes am referred to older adults who, in fact, have seen these articles and want to get off these medications. Here's an article on weaning older adults off sleeping pills. So there's a whole literature about how to taper people off, and how sometimes it's difficult, and how it requires a lot of active engagement between the person who's receiving it and the people who are prescribing them. More on sleeping pills in older adults. So you can see it's just been a series of articles that are reflective of this concern. So here's some good news. This article says sleep therapy seen as an aid for depression, and cognitive behavioral therapy has been found to be effective in not only the treatment of sleep, but it's also been found to be effective when concurrently used with an antidepressant medication to improve depression. For those of you who are mental health familiar, you probably know that not uncommonly for people with more severe forms of depression, there's a disruption in sleep, and it's known that that one of the leading indicators of the improvement of depression is improvement in sleep. So that's just by sort of putting this issue in a larger context. Sleep changes over the course of a person's life. I'm now 69, and I don't sleep like I did when I was 29. And and if you look at this graph, the top one shows basically as you probably know, there's different stages of sleep. And so during the night, you sort of cycle through these different stages. I almost sort of think of it as you're in a pool and you're diving down and you're coming up and you're diving down and coming up. And there are various levels of sleep. There's deeper sleep, there's lighter sleep. There's what's called REM sleep, which means rapid eye movement sleep, which basically is the sleep where we experience dreaming. And it's called that because during this period, our eyes actually move, probably reflecting our own sort of some experience that something's happening. The top bar shows sleep in younger adults and the one in older adults. And I think that probably what is relevant to look at here is we know that as people get older, their sleep gets less deep and there are more frequent awakenings. So if you look at the top graph here, I think you can probably see the cursor I have. You see how deep the sleep goes here, or can go for younger people. You don't see it going as deep for older people. These little spiky things show awakenings. So you don't see that many awakenings in younger people, but you can see multiple awakenings in older people. So essentially, as you get older, your sleep gets less deep and more fragmented. More fragmented in the sense you have more frequent awakenings. The reality that sleep changes is let's wonder if I can. Kara, can I minimize this so I can see the full screen?
Yes.
Oh, how do I do that? Because I don't have part of my stuff cut off here.
You should be able to press escape, I believe, and it should take you out of the PowerPoint mode.
Oh, just do this? No. Let's see. No, I want to stay in PowerPoint. Why? It's just I can't see the full slide because there's a bar here with all of the.
Oh.
Is there a way of minimizing that? I'm afraid if I exit out, I'll go out of here.
Maybe, I'm not sure because I don't see a bar on the screen, so I'm not sure where it's at, unfortunately.
Okay, I just know in some of them I'm going to have to look at some text over in the right and this blocks it out. Okay. Let me see if I can press this. Let's unlock. What's the unlock control panel from screen? What does this say? Quit. I want to do that. Anyway, I'll do the best I can. So apropos to the changes of sleep over the life cycle, this is for the most. The following statement will be true at any age. I sleep better now than I ever will. And I think it's if you sort of think about what sleep is like for babies, they sleep all the time. Teenagers, they sleep differently than we do. And one of the things, as you may notice in teenagers, is there's a shift in their sleep cycle. So as the teenagers tend to want to go to bed late and get up early, that's why it's kind of cruel to send teenagers to school at 7 in the morning. So so sleep just qualitatively generally gets worse. The fact is that so many older adults sort of assume it's normal to have chronic insomnia when they're older, but that's not true. Their sleep is different and probably not as good, but it doesn't mean they need chronic insomnia. Insomnia in older adults. So we know that in general, the prevalence of insomnia is basically having problems falling asleep, staying asleep, or waking up earlier than intended. And people may have all of those or just some of those things. And diagnostically, you need to have had the sleep problems. I think the criterion is every day, almost every day for 3 months. All right. Everybody has a bad bout of sleep problems, but it's typically not chronic. I also might hasten to mention there are lots of different kinds of sleep disorders, and the sleep experts know about that. For example, there are things like narcolepsy, which is people fall asleep during the day, or sometimes people have what's called chronic obstructive sleep apnea, which is basically they fall asleep and their airways close, and they basically are gasping for air, and there are treatments for that, and there are other kinds of treatments. This is a particular type of sleep problem, which is insomnia. Again, problems falling asleep, staying asleep, or waking up earlier. Insomnia is really not good for you. The fact that we do sleep, which puts us in a vulnerable position, biologically must have an important role, and it does. And we know that people with chronic insomnia, it reduces quality of life. There are health problems associated with there are mental health problems associated with. There's increased risk for depression, anxiety, and a whole host of things. That's why it's important for it to be treated. And again, I'm just cutting to the chase here. There's a highly effective treatment for it, which is cognitive behavioral therapy for insomnia. More common in women and more common in white compared to African Americans. The prevalence in older adults of insomnia is twice that of younger adults, and even gets more common into much later middle age. One of my colleagues refers to insomnia as poorly packaged sleep. You have a chunk here, a chunk there, a chunk there. I don't know, for those of you who are older, you might remember a childhood product called Silly Putty. And one of the metaphors is if you took Silly Putty, which is sort of this ball of elastic stuff, and you pull it, the farther you pull it, the thinner it gets, and then it begins to break. And one of the metaphors is that's chronic insomnia. Your sleep is thin and it tends to break. So they're just, they're different stages of sleep, more generally called light sleep and deep sleep and REM sleep. And as I said, as you get older, your deep sleep lessens, more fragmented. Your sleep time, that's the total amount of time, becomes more variable. There's some debate about whether older people have sleep less, or whether it's just it's a different kind of sleep that is less continuous. And also, as we get older, we're generally more prone to go to bed earlier. And I find that for myself. I mean, I don't know, when I was younger, I would go to bed at 12, and now I can't make it past 10:30, and then I tend to wake up early. So there's a change in the circadian rhythm. That is the sort of the biological process involved in sleep. Here is a graph that I show patients when I do cognitive behavioral therapy, which is the two components of sleep. One is what's called the circadian clock, or the circadian rhythm, which you've probably heard of and experienced if you've ever traveled to another time zone, and sleep drive. So across the bottom here, it's a 24-hour cycle from 9 a.m. to 9 a.m. And with regard to the circadian clock, you can see that at 9 o'clock, your brain is saying it's day because the light's out. The light is shining through the window. And as time goes on, as the light diminishes, your brain is registering it's night. and then through the night, you go through the night, and then the next day later, you're back to where you started from. Primarily through light coming through our eyes stimulates certain chemicals in our brain that tells it's day or night. And the other component of sleep is called sleep drive. This is the biological need to sleep. And there's a chemical that's apparently emitted in your brain that actually builds up, that is actually associated with it, the drive to sleep and the experience of being sleepy. So this normal sleep cycle is everything goes well. You wake up in the morning. There's little or no drive. You get to the night. The biological drive to sleep there. Your brain is saying it's night, and then you go through that. So that's the norm. That's sort of the normal rhythm of things. Now, here is the explanatory model for why acute insomnia, that is a bad night of sleep, becomes chronic insomnia. It's called the Thespielman Model, and the person who developed this is very well regarded in the sleep field. And he basically, this is a commonly referred to model to explain things. So I know there are a lot of colors and things and bars, but it basically shows over here how chronic problems develop. On the left here, it's called sleep disturbance intensity. It's from 0 to 100. It's kind of arbitrary. You know, 0 is nothing, 100's the worst, and 50 is, I don't know, sort of a bar where sleep problems become clinically meaningful, right? So again, it's somewhat arbitrary, but and there are three pieces of this. It's called the 3P model: predisposing, precipitating, and perpetuating. And I'll explain what they mean. Predisposing, which is the bluish color, as reflected here, is your biological predisposition to have sleep problems, and we're all different. And so some people I know could sleep through a 3-alarm fire, and other people, you know, a breeze on the window would wake them up. So we have different levels of our propensity to be aroused. I generally find people who are more prone to anxiety tend to be less good sleepers. So this is the baseline. This is just where you start out. It could be down here, it could be up here. So on top of whatever your biological predisposition is to sleep problems, something happens. That's the precipitating event. So what are common things? You had a fight with your spouse or your partner the night before. You're having financial troubles. The COVID thing strikes. There are political developments that are concerned to you. You think you're going to lose your job. All these things can take your normal sleep, and you have some poor nights of sleep. That's adaptive. It's good. Sometimes it's good to be able to stay awake. And that's all normal. Everybody has bad nights of sleep. The problem is that a poor night of sleep, the acute sleep problem, can become more chronic. And so the model here is that this would say there's a stage in which this becomes more like this. You notice the precipitating event that begins to diminish, but you still have it, because you begin to do things in response to your acute sleep problem that begin to perpetuate it. And then pretty soon, and we'll explain how that works, pretty soon the problem that initially triggered it is going away, and now you can begin to develop a more chronic sleep problem that takes on a life of its own. And I'll just tell you, among the people that older people that I see, as you might recall, I work in our geriatric primary care clinic, the Martha Stewart Center. So the geriatricians send patients to me, and pretty routinely, once the person is sent to me, I ask them how long they've had insomnia. Commonly, people say for years and years. So some people just have, and I'll say, do you remember what went on at the time that you began to have sleep problems? I remember a woman in her 80s said, I remember when I began to have sleep problems. I was a child living in London, and the Nazis were bombing the city. And I've had problems ever since then. So it's fairly common. So what are the things that you start doing in response to your acute sleep problems that begin to begin to perpetuate it. So what some people, there are sort of natural, understandable things that people do. So let's say you had several nights of bad sleep. What you might want to do is what they call extend sleep opportunity. So you go to bed earlier to catch up on the sleep, right? Or you sleep in later, or you start napping to catch up on your sleep. What in the terms of the sleep people, they call it your sleep homeostasis, your natural rhythm of this buildup of pressure to sleep biologically, and then its dissipation during the night. So that gets disrupted. Your circadian rhythms get disrupted. And so what happens is that your normal expectable rhythm of sleep, which involves a dance between the knowing it's night and having pressure to sleep, gets all screwed up, as well as your body's understanding is this is the time I sleep, this is the time I'm awake. So your pattern gets screwed up. Then people start doing things like, drinking. So you're tired during the day because you start drinking a lot of coffee, and you might drink coffee later in the day. And by the time you go to sleep, that caffeine's still in your system. And apparently, what caffeine does is it decreases that chemical that builds up during the night that's involved in the pressure to sleep. Then you're sort of whacked out during the day. You don't go to the gym. You're just so tired. So pretty soon your body, which expects a certain level of activity, is not getting it. And we know that the more active people are physically during the day, generally the better that they sleep. So things are getting out of whack here. And then people begin to sort of change their sleep routines. They fall asleep on the couch, or they sleep in other places they normally do. Some people start drinking alcohol to knock themselves out. Alcohol will get you to sleep, but it won't keep you to sleep. And I have had a number of people that I have worked with out of desperation were sent to me. They were drinking large amounts. These are older adults drinking large amounts of alcohol, desperate to get sleep, drinking the equivalent of 5 standard drinks just to go to sleep. Now you can imagine how that is. And I had one woman who basically in the middle of the night fell down and broke something, like a bone, because she was basically drunk during the middle of the night in an effort to try to go to sleep. Now, this is not a person who had a history of alcohol problems, just desperate to go to sleep. So that screws things up. Then people start taking sleep medications, which the doctors will give them, which can be very effective in the short run, but then in the long run, people basically become either psychologically or physically dependent upon them, and then need more of it. All right. So the whole thing takes on a life of its own, which is a problem. And pretty soon you have chronic insomnia. Okay, here's alcohol. I know I have people now taking marijuana. It's not entirely clear what the effect of that is. People take over-the-counter drugs, sleepies or whatever they're, something PM, not realizing that the active ingredient also is something called Benadryl, and perhaps other things too. But those are not good drugs to take for older men with prostate problems. They increase the risk that you'll have further prostate problems. And sometimes people take melatonin as a hypnotic, meaning something that they believe is going to put them to sleep, but it's not a hypnotic. What it basically does, it's the chemical that's involved in the circadian rhythm that tells you that it's night, and often people are not taking the right amount, and often people are taking it just before they go to bed, when according to the sleep people, you take it an hour or two before you go to. So it all gets complicated, and there are all sorts of problems that develop. The good news is there are treatments for insomnia. They come under, their relaxation approaches. These are the names of things. Relaxation. So that can be helpful sometimes. to relax yourself before you go to sleep. Stimulus control, it refers to, and we'll talk some more about this, is basically using the bed basically only for sleeping, none other things. Otherwise things get confusing in your brain. Is this a place to sleep or watch TV? Sleep restriction is, and we'll talk some more about it, is restricting the amount of sleep you get in order to build up the pressure to sleep. Cognitive therapy is part of this package of cognitive behavioral therapy. Sleep hygiene are basic rules for sleep, like go to bed at a regular time, and don't drink before you go to sleep, and don't have a big meal, and don't smoke cigarettes, or other things that stimulate you. So all these things are approaches that have been used, and to varying degrees. Cognitive behavioral therapy, which is what we're going to talk about here, is the treatment that I was formerly trained in. I was formerly trained by a group of sleep people at the University of Pennsylvania, just terrific people. And again, I'm so appreciative to them because they not only study this and teach it, but promote it. Here's the bottom line. The problem is, although this is the most effective treatment there is, very few people have been trained in it. And so that's why I felt particularly grateful to be able to do this. Does cognitive behavioral therapy work for older people as well as younger people? And the answer is yes. And the research results are just excellent. 80% of participants show meaningful improvement. Wake time is decreased, sleep time increases somewhat. So the bottom line is, we know the issue is that most of these studies have been conducted on older people, I don't know, in their 60s. The question is, as sleep gets more complicated and more problematic, and people have increasing health problems, does it work for that group? And I'm going to talk about my experience of doing that. So here are the core components of it, which is this. You do what's called a sleep diary at the beginning. I'll show you a copy of that. And you basically look at different parameters of sleep. You're most interested in how much time the person is actually sleeping. Not uncommonly, people get into bed at 10 and not fall asleep till 12, and then wake up in the middle of the night, and then get up at 8 o'clock. So they may intend to get 8 hours of sleep, but let's say they only get 6. Sleep restriction is, as part of this treatment, is restricting your sleep initially to the amount of time you're actually getting. Stimulus control is based upon, for some of you probably heard of Pavlov's dog, which psychologists call classic conditioning. Pavlov had a dog, and he noticed that when he was bringing the food to the dog, he salivated. Then he would ring a bell with when he brought out the food, and pretty soon he'd get the dog to salivate simply by ringing the bell. It's called classic conditioning. The sleep people say the problem is your bed, which is normally associated with relaxation, increasingly becomes associated with arousal. The bed, which was the place of relaxation, now becomes the torture chamber, where you're up all night, you're worrying and stuff. So pretty soon the bed becomes a stimulus for arousal rather than relaxation. And the sleep people tell a story of somebody who's in the living room, falling asleep on the couch, turn off the TV, stumble, get into bed, and are wide awake. And one explanation is they've just gone to something that triggers them that is associated with arousal. So that's one of the components of this thing, to make sure that people are only using the bed for sleep, or if they're having sex, for sex. There's some hygiene, there's some education about this too. And there's also the cognitive part. The cognitive part is basically working with people about their propensity to catastrophize and get all worked up about sleep problems. That only makes it more likely that they're not going to sleep. Oh my God, I am falling asleep. Oh my God, how am I going to get to work tomorrow? Oh my God, once I get to work, I'm going to fall asleep, and then I'm going to fall asleep, and I'm going to get fired. People get into all this kind of stuff. So part of it is helping people to change the way they think about things in a way that's less likely to promote to anxiety. So in the treatment of sleep, here are some key concepts. So what you do is you use a sleep diary, and again, I'll show you a sleep diary. It's pretty straightforward, but these are common terms that are used that get to some critical ideas. One is the total time in bed. Again, somebody may spend a lot of time in bed, but we're also interested in the total time, their total sleep time in bed. So of course they have acronyms for that. TIB, time in bed, total sleep time. So not uncommonly, I find that people are in bed much longer than they're sleeping. And there's something called sleep efficiency, which is the ratio of total sleep time to time in bed. That is 100% sleep efficient. You get into bed, you sleep all night, you get out, right? A 50% sleep efficiency is you're sleeping 50% of the time that you're in bed, okay? Another concept is called sleep onset latency. What is that? We call that sometimes initial insomnia. That's the amount of time it takes you to fall asleep. So remember the three basic types of insomnia. The problems falling asleep, staying asleep, or waking up too early. So of course they have fancy names for all of this. So sleep onset latency is time to fall asleep. Wake after sleep onset, that's the amount of time that you're up during the night when you would like to be sleeping. And early morning awakening is how much earlier are you waking up than you would like to. Okay, so those are important things initially to find out from the person, and which you will glean by doing a sleep diary. So here's a partial showing of a sleep diary, and a sleep diary, which I just actually did with somebody today, and I looked at his first results of that. And there's 7 columns for each day of the week. You ask people to fill it out at the beginning when they wake up in the morning, and then you basically ask them things like, did you nap or doze yesterday? Napping and dozing later in the day is much more likely to affect your sleep. And some ratings, how would you rate your sleep? You didn't take anything for your sleep? When did you get to bed? When did you intend to go to sleep? How long did it take you to go to sleep? Remember, that's indexes your problems with falling asleep. Oh, did you wake up? How many times? If you think about it, how much time were you in total awake during the night? That's your middle insomnia, or the wake after sleep insomnia. When did you wake up? When did you get out of bed? When did you want to get up? How would you rate your sleep? So you can see these are fairly straightforward things. And I find with most people, once you explain it to them and they start doing it, they use it. And so people fill these things out at the beginning to get a baseline sense of their sleep, from which, among other things, you derive how much time they're actually sleeping, and then you put them on the program. Let me see here. So I just saw a guy today who has not so bad sleep problems. He's probably sleeping about 6 hours a night. Would like to sleep 8. So he filled out a sleep diary. We got that information. His sleep is kind of variable during the week. I said, so here's the deal. So if you want to do this, what time do you want to wake up in the morning? He said 6 o'clock. I said, it's okay. So you're getting about 6 hours of sleep. You can't go to bed until 12, right? And so people don't like to hear that. But I explained the reason for it. He's like, oh, what if I tend to fall asleep and it's going to be hard? I said, it's all going to be hard, but it's going to be worth it. So as you can see, the sleep restriction is restricting his sleep opportunity from 12 to 6. And essentially, he has to get up at 6 o'clock every morning, even if he had a terrible night. He has to push through the day, which in the first couple of weeks is going to be hard because he's probably going to be sleepy. You can take a nap earlier in the day, but then he has to push himself to stay up till 12 o'clock. So it's not that the stuff doesn't work, it's just motivating people to do what is hard. And of course, changing habits is hard. And also, the bed is only for sleep. And so, you can't watch TV in bed. You can't get into bed until 12 o'clock. If you wake up in the middle of the night for more than 15 or 20 minutes, you got to get out of bed and just do something else. No eating in bed. So this is the stimulus control part. We want to just have the bed reassociated with relaxation and sleeping. So the two components are sleep restriction and stimulus control. So my sleep teachers taught me that if people don't get better in 2 weeks, they're not doing it. It's that powerful, and it's true. And that's been my experience. So I want to talk with you a little bit about what my experience has been. So I'm in this large, wonderful department of geriatrics at Mount Sinai Medical School. We're the first department of geriatrics in the United States in a medical school. I work with wonderful people. And for those of you who are familiar with geriatricians, they're the holistic doctors of our age. I have terrific colleagues, good-hearted. And I'll tell you, during this COVID thing, God bless my colleagues. They have just done so much incredible work under such difficult circumstances. So I work there. I work at Mount Sinai 3 days a week. I see a handful of patients, about 8 hours a week, and I'm referred patients by the geriatricians. We have a geriatric fellowship program, which people are learning to be geriatricians and social workers, and I do a lot of different things there. I provide I do treatments for depression and anxiety, and then the sleep. So I've been there for about 7 years. So I mentioned, I got formally trained in doing this cognitive behavioral therapy, and I also, a part of that, got consultation from a terrific sleep guy named Don Posner. He was just one of the best people in the country who taught me how to do this. So here's what has happened over 4 years. This is my summary of things. So over 4 years, I put my files together, and I may have mentioned my colleague and I are going to publish a paper soon on this. 70 people were referred to me, all right? And some of those people referred actually were not good for it. Why? They typically had sleep apnea, which they needed to, which needed to be treated first. So we would typically then refer them to our sleep medicine group that would put them in a sleep lab and check that out. But among those 70 people, 28 said they didn't want to do it. And that's what's so interesting, because in the end, it's like you have a highly effective treatment for insomnia, and yet about half the people won't do it. And I'll talk about why people won't do it. And then about 34 people, I call them engagers, and most people finished. And of the completers, most everybody got better. And I have some data on that. So my question is, what differentiates people who refuse to do it versus people who have completed? And they really didn't differ that much, except the people who refused tend to be older. The average age of people who we treated who were about 77, which is about 10 years older than most of the studies that have been. So we're beginning to see among the older adult population, it works. The refusers were older. Yeah. And why did people refuse? It's too much effort. But I mean, people would say, oh, I'm not filling out those forms, or that sounds too hard, or sometimes they would just sort of punt it and give a vague response, which meant they didn't want to do it. So there's some people just didn't want to do it, which is fine. If they didn't want to do it, they didn't do it. Because I would say, if you want to do it, you got to do it 100%. So the people that were treated all had insomnia disorder. They didn't have any other sleep disorders. Here's the range of time that it took to treat people after we gathered the baseline information was from 2 to 16 weeks, but the median was 5 weeks, and the average was 6 weeks. So this stuff gets done pretty fast. It usually takes a couple of weeks to do an intake and gather initial data, but once people do it, it doesn't take that long. And here are the people. They're mostly white, educated women. Now the question is, with this, what about people who are less educated or lower socioeconomic status? That's a good question. Although among mixed age populations, it doesn't look like it looks like these results are generally more durable in lots of different populations, including in the VA, which has done a lot of this. The average age 77, and it was interesting. I wanted to see if people had mental health diagnoses, and it's interesting. Among this group, 13% had diagnosable depression, 10% anxiety, one person with bipolar disorder. So about 30% of the people had some mental health related problems based upon my assessment of them. 10% were on anti-anxiety drugs, and 24% were on antidepressants. So you can see, it's people have some concurrent complications. Then, if you look at the health status, the number of medications that people are taking on average were 7. So we're talking about people who have these are health medications. These are other medications, and on average, they had 10 or 11 medical problems listed in their chart. So people are having these are people who are having increasing health problems, as is evident when people get older. And the vast majority of people said they had had chronic insomnia for a long time. So these are people the doctors would often say, I don't know what I can do other than give them meds. They've insomnia forever, and what can you do about it? And then on the chart here, it shows what were the targets. So some people have problems falling asleep, staying asleep, or waking up early. And so for people who have these problems, these are in treatment, these are the problems we targeted. So a variety of things, but mainly problems falling asleep or staying asleep. So here is the data. So I know for those of you who are not so interested in data, I'll just try to just talk about this. The bottom line is when we followed people from when they came in to when they finished, we had wonderful outcomes here. And the way you sometimes judge an outcome is looking at the intensity or the power of the outcome. It's something called effect size, and there are ways of judging how much change there is. I mean, if you can have a little effect, but in the end, most people would say, well, I'm a little better, but doesn't make that much difference. Or you can have an effect in which people say that really helped, and I would say the vast majority of people said that really helped. And one of the indexes of this, which is a measure I use, called insomnia severity, which includes the patient's report of how much better they feel, they had a huge effect size. You can't make it bigger than that. And this is pretty much consistent with what you get with younger populations too. People were less sleepy, they were less depressed, they were less anxious, and they showed meaningful improvement in terms of the symptom that they came in that they were most concerned about. Notably, the amount of time they slept didn't change that much, and that's not that much different than other research. Why is that? We mainly are aimed at improving the quality of sleep, and the amount of sleep is something we're less concerned with. And in the end, you generally found, although people are maybe not be getting that much more sleep, the quality of sleep is so much better. And there's some studies to suggest over time, when you complete this, that people begin to get more sleep and they get more quality sleep. And for most people, the efficiency of sleep, the amount of time they were sleeping while in bed increased significantly. And here's just another way of looking at it. Which is, could you, from the symptom that they came in, could you notice a 50% reduction in it? And for most people, you see these reductions. And also, it's notable to mention that a subgroup of people came in on sleep medications like Ambien or sometimes people are taking Benadryl, which is really not good to take, or other kinds of sleep medications. Almost everybody discontinued the medications. The doctors tapered them off. And then we looked 1 year later, and the vast majority of people did not even have a mention of a sleep medication in their medical record the year later. So here, I'll finish up here. I don't know, this is somebody I recently treated. A guy in his 80s, well-educated, history of depression, 7 years of insomnia. His big problem was waking up in the middle of the night, had a whole bunch of medical problems. He lots of medical medications. This is not uncommon, right? So you can see this is not an uncomplicated situation for somebody, right? So he came in, and let me just show you what happened. This is a way of tracking over the 5 weeks that I saw him, and the red line there, that measures the number of minutes he was awake in the middle of the night when he started. And he was awake about an average of an hour and a half a night during the week. The other things at the bottom, the blue line, that's the number of minutes to fall asleep, and the green line is waking up too early. That wasn't a problem for him. The big problem was he woke up in the middle of the night. He was up for an average an hour and a half. Within the first week, you can see dramatically that came down. He was adherent. He did what he was supposed to. It was hard to do. and he showed significant progress in relatively short period of time. I just finished with a woman, about a month ago, excuse me, who we began the sleep treatment before the COVID thing and continued over the phone. Even in the middle of COVID, she showed over the course of, was probably 7 weeks, not as dramatic, but a steady decline in her sleep problems. And I know sometimes you look at these things and say, well, that was the best case you ever had. But I typically find that most people show this kind of improvement. Let's see. Okay, so that's my quick review of sleep issues and my experience with it. So, Kara, do we want to take some questions?
Yeah, so we do have some questions. So we have one person who asked, how can you calculate how long it takes you to fall asleep? Does the person wear a Fitbit or an Apple Watch to record it, or how do you go about getting that information?
Okay, so we find in doing this that the person's best guess is probably good enough. There are people who wear these different indicators like Fitbits and things. The sleep people say the problem with them is that they are not always accurate. And sometimes people start thinking they have sleep problems, not because they do, but because their Fitbit tells them to. One of the sleep people calls it Fitbit-induced insomnia. So you got to be careful. There is something called an actigraph, which people will be strapped. They will strap that to the person, which is sort of one of the gold standards for indicating your sleep. The real gold standards, however, is going to a sleep lab and spending the night. And you get connected to all sorts of things. So I would not necessarily feel that those devices, which are not created by the medical community to measure sleep, I would take them with a grain of salt. But generally, I find most people can give you a general idea of how long it takes to fall asleep, how long they were awake during the night, and whether they woke earlier than intended.
All right, and then we have someone else who's asked the question. So if the person is getting 6 hours but wants 8, would you restrict them to 6, midnight to 6, or how would they transition to 8?
Oh, well, first of all, sometimes people believe that they need more sleep than they actually need individually. There's a considerable variability among people. So sometimes people begin to develop sleep problems because they think they should sleep longer than they're actually even capable of. So if somebody, and sometimes I'll say people, a few years ago before you had this, how many hours of sleep did you sleep? That gives a pretty good baseline. So if a person wants, the first question is, if a person sleeps 6 hours and they have relatively good sleep, then they may not need any more sleep than that. But if their sleep is characterized by the kind of fragmented sleep that I've been discussing, and they previously slept more, then the first thing to do would be to get better quality of sleep. So in this approach, cognitive behavioral therapy for insomnia, once people's sleep is better, we add time. So which is usually 15 minutes every 3 days. But as you can see from the results, you don't see that much increase in time, but you see dramatic increases in the quality of sleep.
Okay, and then we have another question asking, is the 12 p.m. bedtime too rigid, or should it be, or could it be 10 p.m.?
I'm sorry, what was that question again?
Is 12 p.m. Midnight, is that time too rigid, or could 10 p.m. be an option?
Oh, I was just using that as an illustration, right? So some people, it depends upon the person. I have, let's say that you needed 8 hours of sleep and you wanted to go to bed at 10. Well, So if you did that, then you go to bed at 10 and you would be up at 6. Some people think if they go to bed like at 7 o'clock, they should still sleep to 6 o'clock, but that's more time than they would probably need. So uh, the first question is, how much did you actually need? And often, historically, when you were getting better sleep, how much time did you generally sleep is a pretty good indicator of that.
Mhm. Mhm.
Does that
And then
answer the question?
I think so. That I didn't get a follow up from them, but I do have someone asking if you could speak a little bit more about how you address the catastrophic thinking.
Okay, so one of the things is just it's not uncommon. You hear people saying, "I woke up in the middle of the night and then my mind started racing," right?
Mhm.
So one thing is, at night, only part of your brain is working. So the frontal, the part of your brain that's involved in higher order thinking, called the frontal lobes, is kind of on sleep mode. So in the middle of the night, I don't know about you, have you ever woken up in the middle of the night and something that sort of bothered you during the day loomed so big that it just seemed like it was insurmountable? Part of the problem is that you didn't have your higher order thinking skills to work on it, and it just comes out undisguised. And so it become frightening for people. So one of the things you say to people is, the worst time to do problem solving is in the middle of the night. So sometimes what you get people who are on the anxiety and worry prone thing is to keep a sleep diary. So they have a dedicated time early in the evening in which they write down what their worries and concerns are, which can sometimes be helpful. So in the middle of the night, when you have that itch to start worrying about things, you can say to yourself, I've written it down. This is not the time to do it. I have plenty of time tomorrow to take care of it. But not uncommonly, the catastrophic thinking comes around the sleep stuff. Like,
Mhm.
oh my God, I won't be able to function tomorrow. Oh my God, I have a full day. I'm going to be totally exhausted. And all of this kind of stuff in which you engage in all of this sleep related worry and effort. And so, among other things, um, you point that out to people, you help them understand it, and then you give some alternative scripts, right? You reality test their idea that, oh my God, I'm not going to be able to function. I'm gonna get fired, or whatever it is, and just say, has that ever happened? Oh, you've had insomnia for 7 years. Has that ever happened to you before? What is the likelihood of that actually happening? In a way to use some just questioning that belief and the veracity of that belief. But also you help them get a different approach to sleep, which is like, oh, you wake up in the middle of the night. You wake up in the middle of the night. You know what? Just go in the living room, do something you enjoy, give up any hope that you're going to sleep, because you know what? If you don't sleep well that night, you're going to probably sleep better the next night. And if not the next night, almost certainly the night after that, because you're going to be so exhausted that your body is just going to push you into a sleep. So,
Mhm.
and so you begin to talk in a much more relaxed way about sleep. You begin to increasingly show people that as they make efforts, their sleep is getting better. You show them the graphs and things that are to build their motivation. Um, and as people get better sleep, they're less likely to be so worried about it. Sometimes I find that as I'm finishing up with people, and then they have a bad night of sleep or something, think, oh my God, I'm back to where I was. So I anticipate that. I'll say, you're going to have bad nights of sleep. Don't think that you're back to where you are, because you're much better position you are. You're going to have that thought, but that's not true, right? So
Mhm.
you provide alternative ways of thinking about things. You provide people with alternative scripts. You give them tools to question the reality of what they're thinking. You give them tools to sort of take their propensity to worry and have them write it down and sort of like put it in a little bit of a box so it's not free floating.
Mhm. Mhm.
I find most
Definitely.
people get that message.
Mhm. Yeah, they did. And now we have a few people asking about how would you apply this model or modality with someone who has dementia if they were going through wakefulness?
Okay, so that's a really good question. And I have sometimes people have been referred to me with cognitive problems, and I find that the few people I've worked with, I need to work with their caregiver to work in this. So here are some of the more general problems with people with cognitive impairment and sleep. Just above and beyond whatever damage might be being done in the brain that might be affect the sleep circuits, you got people who are often not that physically active during the day, people for whom they may be not having regular sleep times, maybe napping during the day, people who may be indoors and are not being exposed to natural light, which helps regulate the circadian rhythm pattern. And so what can happen is the person just gets into very bad sleep habits. And so I would say, as a general rule, if you have a person with cognitive impairment, make sure they get enough physical exercise and engagement, get people out as is possible, or at least sitting in the sun, in getting direct sunlight, curbing curbing naps, except if they tend to be earlier in the afternoon, having a regular time to go to bed and a regular time to get up, and that should be helpful. But as with anybody, if you get into bad habits, habits are hard to change. But in the end, the behavioral aspects of working around dementia have been found to be helpful. There are some of my colleagues who do work around behavioral approaches to dementia find that using a behavioral approach can decrease the frequency of behavioral problems, can decrease the amount of depression that is experienced by the person with cognitive impairment as well as the caregiver. And in the same way, I think using some basic principles around sleep are going to be helpful in terms of improving at least some dimensions of sleep with people with cognitive problems.
Definitely. And we have one last question before we wrap up today. About how do you address the psychological dependence on prescribed Xanax or Ambien, even when lowered to a minimum dosage to finally come off all medications?
That's such a great question, and it was one that comes up regularly. So the sleep experts said to me, these sleep medications like Ambien or whatever people tend to poop out after a while. That is, they have more of a psychological effect than they do have a biological effect. So it's part of the sleep ritual. You develop the belief that the only way you can get to sleep is put this thing in your mouth, right? And my experience is in working with people that who are tapered off these medications, which sometimes they've been on for long periods of time. Most people are surprised that it's so much easier to get off of them than they thought. And what happens is that once they get off, and if they're willing to do cognitive behavioral therapy for insomnia, they will be so dead tired because of sleep restriction by the time they go to sleep that they're going to fall asleep. And the notion that the only way they can get to sleep with sleep medication sort of disappears because they're not taking the sleep medication, and because of this approach, they're actually falling asleep. And the sleep medication issue just kind of disappears. So I would say that it's more of a psychological belief. It's an expectancy that unless you do this, that won't happen. That's my thought about it.
All right. Well, I just want to say thank you again, Dr. Hinrichsen, for being with us today. Definitely getting a lot of people saying thank you for going over this. Very appreciative of your time. And so we have another Care Connection series that will come up in August. And if you have questions for either us at the Alzheimer's Foundation or for Dr. Greg Hinrichsen, you can feel free to reach out to us and we can connect you. So thank you again so much.
Thank you.
All right. Everyone have a good day.